Okay, we're going to get started. Good morning, everyone. And thank you all for coming. For those of you who don't know, my name is Christina Cadalco, and I'm on faculty here in the Division of Pulmonary and Critical Care Medicine. And not surprisingly, my focus is in pulmonary hypertension. I'm excited to either welcome you back or welcome you as newcomers to the now second installment of the Pulmonary Hypertension Grandrounds series. This series, which is generously sponsored by the Vera Moulton Wall Center for Pulmonary Vascular Disease, has been set up to hopefully serve to bridge this gap between clinical medicine, clinical research, and basic science research in the field, in the complex field of pulmonary vascular disease. And as I mentioned, this is our second year running, and I hope to have similar success as we did last year. We already have a talented group of speakers scheduled to come and visit us. Usually the series runs on the second and fourth Mondays of every month, barring any major holidays or conferences. And so today's an exception, but that's okay because it's an exceptional day in many ways, thanks to our internationally renowned expert speaker in pulmonary hypertension, Dr. Kawut, and thanks to the fact that we are acting as host to the Evans Family Lecture today. I'd like to first introduce my mentor and colleague, Dr. Roham Zamanian, who is the director of the Adult Pulmonary Hypertension Service at Stanford, and he will introduce his friend and fellow warrior against pulmonary hypertension, Dr. Stephen Kawut. Thank you.
Thanks, Christina. We owe a lot to you and your organization of this lecture series and the educational aspect of our program. I just wanted to start off giving a little bit of a historical perspective on today. It's an honor to have a colleague and a friend at the 14th Evan Family Lecture. The Vera Moulton Wall Center was established in 2001 with primarily the missions of excellence in clinical care, education, and advocacy for patients, as well as cutting-edge clinical research. And we've come long and far with it. The program has both an adult and a pediatric group. Some are photographed here. And for me personally, I think the excitement currently and really the point of impact here is the fact that the Wall Center has been and its faculty have been successful in the development of the next generation of therapeutics for this disease. And as you see, some of them have been developed with the help of the Wall Center. All of them have, and they've moved on to industry partners with FK506, with Mark Nichols' work with LTB4 antagonism, and hopefully the one to come with Elephant and Marlene Rabinovich's work. But essentially, I think after the many years that the Wall Center is beginning to address its goals and its mission, so of clinical excellence is there, of clinical research and its impact in the modern therapeutic era, it's there. And of course, this is a slide that I borrowed from our 10th annual celebration from a couple of years ago, highlighting the number of fellows that have gone through the subspecialty, a curriculum-based program for training the leaders of pulmonary hypertension, clinical care and research, which is what is under the guidance and directorship of Christina currently. So this is where we are in terms of the missions. One of the tools that the Wall Center has used to achieve its missions has been reaching out to international colleagues, and I want to put prior Evans lecturers here up on the screen here. We've had both the Dunleavy Lectureship and the Evans Family Lectureship, and there have been some very substantial clinical and basic researchers that have come through this place and given the Evans Lectureship. So it's with with this sort of distinct background and pleasure and this point in time in the Wall Center's history that I have the pleasure of introducing my friend and my colleague, Steve Kawut. Steve is the professor of medicine and the director of the pulmonary vascular program at Perelman School of Medicine at the University of Pennsylvania. He received his biology AB at Harvard College, moved on to Yale for his MD training, and he did his residency and fellowship at the University of Pennsylvania. He also got a clinical master's in clinical epidemiology at Pennsylvania, did some preliminary faculty work at Columbia, and has gone back to University of Pennsylvania for the rest of his work. A lot of you who know Steve will recognize him as really an authority who is not confounded by pharmaceutical sponsorship in the field. He's led more than 200 manuscripts in mostly high-impact journals in numerous fields in pulmonary vascular disease, interstitial lung disease, and lung transplantation. He's had multiple fundings. The first NIH clinical trial, multi-center trial that I know of in PAH, ASA stat, that was done early in his career, and he's worked on clinical trials addressing the lung-liver interaction. He is such a well-regarded authority, and again, not confounded by pharmaceutical associations, that the FDA commonly uses him as an advisor in review of multiple clinical trials, and that has brought him to the forefront with several publications and FDA allowing him to utilize clinical trial data to look at different parameters, including hemodynamics in pulmonary vascular disease, and the importance of the therapeutic effect on things such as the 6-minute walk distance. And finally, I think that the most thing that he's proud of has impacted my life and many others is his advocacy and mentorship for junior faculty. I think in 20 years down the line, if we look at what Steve Kawut has contributed to the field, is not only great studies, great manuscripts, but also a lineage of hopefully high-achieving, except for me, investigators that will lead the next generation of work in the field. So please help me welcome my good friend, Steve Kawut.
Thank you very much. That was really a wonderful introduction, about 40% true. And I really appreciate the opportunity to come speak and see lots of friends and colleagues here at Stanford. It's really an honor to be the 14th Evans Family Lecturer. So first of all, my disclosures. I've received no personal financial reimbursement and have no financial conflicts of interest. But Penn, on my behalf, has received funding from the sources listed on this slide, either for institutional research or for CME courses. So the first thing I did when I was invited to give the Evans Family Lecture is to figure out who the Evanses were. And my understanding, and please correct me if I'm wrong, the Evanses were friends of the benefactors who endowed the Vera Wall Center. And Dr. John Evans was a cardiologist by training and was actually the founding dean of McMaster University Medical School at the ripe old age of 35. It's a good way to make someone feel unaccomplished, and that I've never been a dean, and significantly older than that. He really pioneered problem-based learning, using cases to be instructive, and I think he may have had a direct impact on my education and development, because he hired David Sackett, really one of the forefathers of clinical epidemiology, who established the first department of clinical epidemiology and biostatistics in 1967. And you may have noticed on my intro slide that I actually am appointed in the Center for Clinical Epidemiology and Biostatistics at Penn. And I have no doubt, like many other great things, we stole that from the Canucks. So I think there may be some direct connection here. So we're going to first talk today about the epidemiology of pulmonary hypertension, specifically as it relates to sex, and then talk about sex hormone risk factors for PAH and potentially some mechanisms, talk about outcomes, again, specifically related to sex in PAH, and then a few thoughts about the future. So from the very first modern description of pulmonary arterial hypertension, then called primary pulmonary hypertension, we knew this was a female predominant disease. David Dresdale, who actually died a few years ago in 1951, published a case report of 3 cases he had seen in New York City: a 25-year-old married Czechoslovakian female, a 35-year-old Puerto Rican housewife, and a 34-year-old white housewife. So even from the first modern report of PAH, clearly there's something about sex which increases the risk of pulmonary hypertension. Despite this being the best established and oldest risk factor for pulmonary arterial hypertension, I think it's one of the least understood, and only probably in the past 10 years have we started to look at why women get this disease more than men. Again, it's very clear that female sex is a risk factor for both idiopathic and heritable pulmonary arterial hypertension. These early studies, including the NIH registry and the cohort from Vanderbilt, suggested that this may affect women more than men, and more recent registry studies confirm that, with large studies from the US, from the UK, and from Spain, confirming that 70 to 80% of individuals, at least with idiopathic or heritable PAH, are women. On the other hand, when we look at other forms of pulmonary arterial hypertension, for example, HIV infection, we do not see a sex difference. In addition, I should say in children, there is also not a sex difference in PAH. And for a disease like systemic sclerosis, while indeed more women than men get systemic sclerosis, when you look at PAH as a complication, it does not affect women more than men within that disease. On the other hand, we did a study, a case control study, looking at portopulmonary hypertension. This is pulmonary arterial hypertension in the setting of portal hypertension and liver disease. And we found that being female increased the risk of this complication by about threefold, and was independent of other covariates, including type of liver disease, autoimmune hepatitis, which appeared to increase the risk, and hepatitis C infection, which actually appeared to decrease the risk. At that time, we were interested in looking more at mechanisms, and so we did a high-throughput genetic analysis. We looked at 100 genes, 1,000 SNPs. Remember, this is about 13 years ago, and this was cutting-edge stuff. You know, we can do whole exomes now in hours. But at that time, this was the approach. And we really curated a long list of genes, whatever we thought might be involved in the pathogenesis of pulmonary arterial hypertension, to look at genetic variants increase the risk of portopulmonary hypertension. We found several genes which appeared to increase the risk, but I want to point out two in particular. That includes aromatase. This is an enzyme which converts estrogen precursors to estrogen, where we find two polymorphism, and estrogen receptor alpha, obviously one of the two known receptors for estrogen signaling. Aromatase lives here in the production of sex hormones. It accounts for the conversion of testosterone and androstenedione into estrone and estrogen, mostly in the periphery. So aromatase lives in the vessels, it lives in fat, and this is what accounts for estrogen production in your body, other than in the ovaries in the premenopausal women. There's another enzyme here, CYP1B1, which accounts for metabolism of both estrone and estradiol into two metabolites, 2-OHE and 16-OHE, and we're going to talk about these in a little bit. 16-OHE tends to be pro-mitogenic and pro-inflammatory, and 2-OHE tends to be anti-mitogenic and anti-inflammatory. So because aromatase accounts for the conversion of these estrogen precursors into estrogen, if we're looking for functionality, then we should be able to measure estrogen, and every increasing allele, risk allele in the aromatase polymorphism should be linked to an increasing amount of estrogen in these patients. And that's exactly what we found for at least one of the polymorphisms. For each additional A allele, there was an increasing level of estradiol in these liver patients. And I think this is the first time this has ever been shown, but we also showed that patients with portopulmonary hypertension had significantly higher estrogen levels compared to liver disease controls. I think that's the first type of PAH which has been linked to higher estrogen levels. Well, we then went on and said, well, this seems like something very simple. Why not just look at estrogen in patients with pulmonary arterial hypertension? And Corey Ventitulo, one of my mentees, rounded up 23 male PAH cases. Again, this is pretty uncommon in men. and compared them to 67 male controls drawn from the MESA study, which is a large NHLBI cohort study of individuals, adults, without clinical cardiovascular disease. She matched on age and BMI, both things that can affect estrogen levels. And so you see the mean age is in the around 62 to 64, BMI around 26, 27. Most of these cases had idiopathic PAH, 9% had heritable, and 22% had connective tissue disease. And these patients were treated with the usual meds that we use in patients with PAH. So we first looked at estradiol levels, and there was significantly higher estradiol levels in men with PAH compared to male controls. We also showed that men with PAH actually had lower DHEA levels, or the DHEA-S, which is a sulfated ester, again, compared to controls without clinical cardiovascular disease. On the other hand, there were no differences in either bioavailable testosterone or in total testosterone between the two groups. Interestingly, in men with PAH, higher estrogen levels were actually associated with lower 6-minute walk distance. So they appear to negatively impact on function. And also interestingly, lower DHEA levels were actually associated with higher right atrial pressure and higher PVR. And DHEA has been linked with several different phenomena. It's age-related. All of these results were adjusted for age. But has also been linked to increased cardiovascular risk and increased inflammation. Well, if this holds true in men, what about women? So this was an easier study to do because this is a female-predominant disease. We looked at almost 80 female PH cases, and again, drawing controls from MESA, used 151 controls, again matching for age and BMI. Mean age here was around 68, slightly older than the men, and BMI around 26 to 27. The reason for the age difference in this study compared to the last study is because many more women had connective tissue disease as the etiology of their PAH, and women with connective tissue disease, scleroderma, tend to be older. So there were 42% idiopaths, 54% who had connective tissue disease, and 4% who had congenital heart disease. These patients were mostly functional class 3 and had a 6-minute walk distance of 330 meters. Once again, when we looked at estrogen levels, you can see that women with PAH had higher estradiol levels than controls without clinical cardiovascular disease, and once again, almost the exact same finding of a lower DHEA levels in cases with PAH compared to controls without. We went on to look at the associations of these hormones with severity of disease. And again, just like in the men, higher estradiol levels were associated with significantly lower 6-minute walk distance, and also were associated with a somewhat higher right atrial pressure with no links to mean pulmonary artery pressure, cardiac output, or PVR. On the other hand, when we looked at DHEA, higher levels of DHEA were actually linked to higher 6-minute walk distance. So this was a kind of a positive association. And higher levels of DHEA were linked to lower right atrial pressure, lower mean pulmonary artery pressure, somewhat higher cardiac output, and a bit lower PVR. So DHEA seemed to have a beneficial effect or a beneficial association in these patients. So in sum, where are we now? It appears that female sex increases the risk of idiopathic, heritable, and portopulmonary hypertension. I don't think that's too controversial. It seems that genetic variants in aromatase and potentially higher levels of estradiol are linked with pulmonary arterial hypertension in men and women. It appears that higher estrogen levels and lower DHEA are linked with worse disease severity. And this leaves us with a question: how does female sex or how does estradiol cause pulmonary arterial hypertension? Well, there's over the past decade or slightly more has been a gradual trickling of literature on this topic. So Eric Austin published this very nice paper in 2012 where he looked at BMPR2 expression, the genetic mutation which causes one kind of heritable PAH, and found that from cultured lymphocytes, women actually have lower BMPR2 expression compared to men. And these are normal individuals. So normal individuals, sex difference in BMPR2 expression. When he took the lymphocytes from men and actually treated them with estrogen, he actually saw a reduction in BMPR2 expression. This is the data, these are the data from lymphocytes, and these are from endothelial cells. So there's something about female sex and potentially estrogen which downregulates BMPR2. Eric went on to perform a very nice study looking at genetic polymorphisms in CYP1B1. That was that enzyme I showed you before, which metabolized estrogen to one of two compounds. And he found that specifically in women, genetic polymorphism in CYP1B1 was associated with the risk of having the disease. This is affected mutation carriers, so women with BMPR2 mutations who had PAH, and this is unaffected mutation carriers, women with BMPR2 mutations who did not have disease. These are the same data for men. And you can see that there's a difference here in terms of the wild type polymorphism in the risk of the disease. He went on to look at the ratio of 2-OHE to 16 alpha. These are the products of CYP1B1, and found that those individuals who were affected, who were cases with PAH, had lower ratios and specifically higher levels of 16 alpha compared to unaffected mutation carriers. And then he performed a really nice study published last year in Circulation, where he found that miR29 appeared to account for the mechanism mediating the link between 16 alpha and pulmonary arterial hypertension, and did that very elegantly both with animals as well as with human tissues. Mandy McLean also kind of picked things up here where she looked at whether CYP1B1 was actually expressed in the pulmonary vasculature, and she found that in patients with idiopathic and heritable pulmonary arterial hypertension, indeed CYP1B1, this estrogen catalyzer, was found in the smooth muscle layer, and then was quantitatively increased in patients with pulmonary hypertension. She also had looked at our data on aromatase, and again decided to look to see whether aromatase, this gene or protein which converts estrogen precursors into estrogen, actually existed in the pulmonary vasculature. And while in men she did not find presence of aromatase, in female patients with PAH there was an increased expression of aromatase in the small muscular pulmonary arteries themselves. She also found expression of estrogen receptor alpha in women more than men with pulmonary arterial hypertension, and increased from the baseline or normal state. Whereas on the other hand, she actually found increased expression of estrogen receptor beta in men compared to women with PAH. So hopefully I've convinced you that estrogen and aromatase appear to be important in patients with pulmonary hypertension. Well, it'd be nice to try to decrease estrogen levels and see if we can affect the phenotype of pulmonary vascular disease. Anastrozole is an aromatase inhibitor which reduces peripheral estrogen production, estradiol and estrone, in both postmenopausal women and men. You can't use this drug in premenopausal women because their ovaries are another source of estrogen production. This is a drug that's been approved by the FDA for 20+ years, used by hundreds of thousands of women for treatment of breast cancer, and is actually quite safe, with side effects such as joint pain and hot flashes, decreased bone density, and a small risk of thrombosis, although this has actually only been seen in women with cancer and has not been seen in actually a recent study of women without cancer. Mandy McLean used anastrozole in 2 animal models of pulmonary hypertension. And this is a somewhat busy slide, and I apologize, but I think the message is simple. So here are the animals. She used the Sugen hypoxia animal model and used a treatment model where she first had the pulmonary hypertension established and then administered anastrozole 2 weeks after that. And you can see that in the animals, the control animals treated with the vehicle, there was an elevation in RV systolic pressure compared to the normoxic animals without Sugen. On the other hand, when she treated these animals with anastrozole, she saw a reduction in right ventricular systolic pressure, a reduction in the percent remodeled vessels, and a significant reduction in the percent of occluded vessels. She performed some similar experiments in just hypoxic animal model in the same paper and really showed the identical results. There's also been a lot of interest about insulin resistance and the use of metformin to treat pulmonary hypertension, much of it based on data from here at Stanford. And so she looked at whether metformin could reproduce this effect. And she found that indeed, compared to vehicle, metformin decreased RV systolic pressure in the Sugen hypoxia model, decreased right ventricular mass, or Fulton index, and decreased the percent remodeled vessels. And she also showed very nicely that this effect of metformin was almost entirely mediated by aromatase inhibition and reduction of estrogen. So this really tight link between insulin resistance and the role of estrogen in pulmonary hypertension. Finally, and these are the last experimental data I'll show you, this is a paper that came out a few weeks ago from James West at Vanderbilt, where they have a BMPR2 mutation transgenic model of pulmonary arterial hypertension. And he took a kind of a similar tact. He used both anastrozole and fulvestrant, which blocks estrogen receptors. And again, in a treatment model, after the establishment of pulmonary hypertension, he was able to show that the combination of anastrozole and fulvestrant significantly reduced RV systolic pressure and reduced muscularized vessels in this animal model. The nice part about this study is he went on to try to look at mechanism and actually showed that while in animals with the BMPR2 transgene, they had a reduction in PPAR gamma expression in their lungs, anastrozole and fulvestrant appeared to reverse that or increase PPAR gamma expression. And this is in a prevention model where we started the drugs right away, and in a treatment model where he started the drugs after the establishment of pulmonary hypertension. He also showed that the HOMA-IR, or insulin resistance, was increased in animals in this BMPR2 model treated with vehicle, and that was reduced in animals treated with anastrozole and fulvestrant. All right, well, I am not an animal researcher, and I am not a veterinarian, I'm a physician. And so could these drugs be used in patients with pulmonary hypertension? So this was actually part of my K-24. And fortunately for me, my K-24 started 6 years ago, and all of these basic scientists were doing all this work while I was enrolling patients. And so the timing couldn't have been better. So we decided to try using anastrozole in treating patients with pulmonary hypertension. This was a double-blind, randomized, placebo-controlled trial of anastrozole 1 milligram a day. This is the usual dosage for breast cancer. And we recruited patients both at Penn and at Brown University. The recruitment took from January of 2013 to January 2015, and we randomized 6 patients to placebo and 12 patients to anastrozole in a blinded fashion. The goal of this very small pilot study was to, 1, show the feasibility of doing federally funded studies in pulmonary arterial hypertension, 2, to determine if there's any signal of benefit, to get an effect estimate and make a go, no-go decision, or to see if there were harm, and 3, to determine preliminary safety and side effect profile. This was a 12-week study, included patients with pulmonary arterial hypertension who were either postmenopausal women or men, and who could do the 6-minute walk. And we obviously had to exclude patients being treated with estrogen, who were functional class 4, or who had a history of breast cancer. The primary endpoint of this study was actually 2. Number 1, the change in estradiol levels from baseline to 12 weeks to see if the drug would do what it's supposed to do. And 2, to look at the change in TAPSE as a reflection of what was happening in the lungs and the right ventricle from baseline to 12 weeks. We looked at a variety of secondary endpoints, including lots of sex hormones, other echo measures, a variety of biomarkers, including BNP, insulin, the HOMA index, quality of life, and side effects. As I mentioned, we randomized 12 patients to anastrozole and 6 to placebo, quite similar in age. There appears here to be an imbalance in terms of sex between the groups, but remember, these are very small numbers. If one man had been randomized to anastrozole versus placebo, these would have been identical. So the imbalance here is one individual. Mostly white, and they tend to be an overweight group. About 30 to 40% had idiopathic PAH. 15 to 30% connective tissue disease, and portopulmonary hypertension, congenital heart disease, and HIV. About a quarter to a third of patients were receiving combination therapy for their pulmonary hypertension, and their median NT-proBNP was almost identical. So the severity of illness between the groups was quite well matched. When we looked at the change in estrogen over 12 weeks, we saw that patients treated with anastrozole had almost immediately a significant reduction in circulating estrogen levels compared to those patients treated with placebo, and that was maintained at 12 weeks. On the other hand, we saw really no change in TAPSE affected by anastrozole over the 12 weeks of the study. While we didn't see a difference in TAPSE, we actually did see a significant increase in 6-minute walk distance in patients treated with anastrozole. You can see there's a bit of a difference here even at 6 weeks, and here essentially all patients except these two had an improvement in their 6-minute walk distance. And when you look at the placebo patients, essentially all placebo patients stayed the same to had a little bit slight worsening. The drug was reasonably safe. We saw very few adverse events, very few side effects. I will say we had one patient who had hot flashes and palpitations and night sweats, and I said, oh, for sure this patient is getting active drug. It was a man. And he basically read off the list of menopausal symptoms to me, that he was having all these symptoms. And I said, oh, this guy definitely has active drug. Number one, he had placebo, and this just goes to show, number two, that men are indeed the weaker sex. And why we need to do placebo-controlled trials. So that's my one guy here on placebo having menopause. Oh, he did. But again, my coordinator and I looked at each other, and we said, oh. So what are the limitations of this study? So obviously this is a small study of postmenopausal women and men. It's of a short duration. No hemodynamic measurements. We were only powered to detect large differences in TAPSE and didn't see any difference in those data. It's unclear what the mechanism was of the improved 6-minute walk distance. And we saw no change in HOMA, insulin levels, CRP, BNP, et cetera. So first, this, I think, is the first randomized clinical trial in patients with PAH of a sex hormone targeted therapy or sex hormone manipulation. And I think it's important because of that. But we still don't know how or why anastrozole significantly increased 6-minute walk distance over only a period of 3 months without any change in echo or in other biomarkers. And perhaps we missed the changes in these biomarkers. Perhaps the variability in these surrogate measures was too great to detect a difference. Maybe we needed to have exercise assessments, so maybe resting RV morphology looked the same, but if we were to exercise them or stress them, we would have brought some differences out. Or maybe this is a novel mechanism of estrogen inhibition, a peripheral effect or ergoreflex, a peripheral vascular effect that we don't understand yet. Well, despite not knowing the mechanism, we are pushing ahead with a larger phase 2 study called the Pulmonary Hypertension and Anastrozole Trial, or otherwise known as PHANTOM. If you like the logo, you can thank Roham and Stanford because they designed it. And this is an 84-patient randomized, double-blind, placebo-controlled RCT of anastrozole for PAH, supported by the NHLBI, and for which Stanford is going to be one of the field centers. We're also doing another very small pilot study of fulvestrant. I mentioned before, fulvestrant is an estrogen receptor blocker, and we're using PET scans to look at estrogen uptake in the lungs to see if the administration of fulvestrant blocks that in patients with PAH. So 2 different trials ongoing in sex hormones. So in summary, aromatase is found in the pulmonary vessels in pulmonary arterial hypertension. It appears that both anastrozole and fulvestrant improve experimental models of PAH. But that being said, we've, of course, cured mouse and rat PH a long time ago. I have no mice or rats coming to me for their pulmonary hypertension. So the real challenge here is, what does it do in the humans? And it appears that PPAR gamma and insulin resistance may be mechanistic explanations, at least in the animals, but that remains to be proven in patients. And it looks like anastrozole significantly increased the 6-minute walk distance in patients with PH, but had no effect on echo, biomarkers, inflammation, or insulin resistance. But again, I think we need more data. So let's move from epidemiology and risk factors and mechanisms into outcomes. So despite this disease having a female predominance, things get flipped around when we looked at outcomes. While women have a higher chance of developing pulmonary arterial hypertension, they actually live longer with the disease. And this has been shown in several studies from France, from Spain, from the US, from Germany, that men compared to women have a 40% to 2 times increased risk of death compared to women. Even in systemic sclerosis, men have a 60% increase in the risk of death compared to women. So while women get the disease more, men do worse with it. But why is this? Well, I think a simple person like myself would say, well, this has to be RV function, right? The RV is key to outcomes in pulmonary hypertension, or men have to have worse pulmonary vascular disease compared to women. And this could be either differences at baseline or differences in response to therapy. So let me show you some data, and you can decide which you think it is. So first, these are data from MESA. I mentioned MESA before. This is the multi-ethic study of atherosclerosis, 6,814 person prospective cohort study of adults aged 45 to 84. And this study was sponsored by the NHLBI and focused on subclinical markers of atherosclerosis. So they specifically focused on adults without clinical cardiovascular disease, things like myocardial infarction, angina, AFib. And as you could tell by the name, they were interested in oversampling for ethnic minorities. And so Asians, Hispanics, and African Americans were oversampled. They did cardiac MRI in this study on over 5,000 adults. But true to form, while they looked at the LV, no one read the RV in these patients. So probably more RV data maybe than many studies combined, and no one took a look. So one of my first R01s was to read the RV for mass and function in about 4,000 of these individuals. 4,204 to be exact, mean age of 62, half female, ethnically diverse, as I mentioned before, with a BMI of 28. These patients could have hypertension or diabetes, but again, couldn't have clinically diagnosed cardiovascular disease, and about half of them were lifelong non-smokers. So when we looked at RV mass by age and sex, we saw 2 things. First, with older age, RV mass actually decreased rather than increased, which is what you might expect based on the LV from what we know about aging myocardium. In addition, at every age, men had a greater RV mass compared to women. And this is after adjustment for race, ethnicity, body size, exercise, treatment for cholesterol, antihypertensive treatment, essentially everything you could account for. This was independent, and this was even independent of LV mass. So there was a disproportionate increase in RV mass in men compared to women, even independent of what was happening in the LV. When we break this down by race and ethnicity, again, men in general had higher RV mass compared to women, but you can see there are some differences here, and even some differences between races, whereas male Caucasians or whites tended to have higher RV mass compared to male Chinese Americans. When we looked at women, there weren't really differences between these 2 groups. And again, this was both independent of a variety of confounders and independent of the LV. When we looked at RV ejection fraction, we found that men of all races and ethnicities had significantly lower RVEF compared to women. And we're talking 4 to 5% here in normal individuals. Keep in mind that we think that 3% is a clinically significant difference in patients with pulmonary hypertension, so that 4 or 5% in a normal population is actually a huge difference. And again, this persisted after adjustment for covariates, and again after adjustment for the LV. So it appears that men without clinical cardiovascular disease, male adults, have higher RV mass, lower RV ejection fraction, and I didn't show you the data, but they also had larger RV volumes. And this is really consistent with what other human studies of the LV and in animal models of LV failure. It seems like whatever model of LV failure you want to pick, whether it's ischemic or aortic stenosis, male animals always have worse LV function compared to female animals. And again, when you look in human studies, we see the same thing. There's been some work looking at the effect of estrogen on RV function in animal models. Tim Lam has done most of this. He's going to come visit, so I'm not going to steal his fire. And then it also appears that testosterone may actually increase RV mass and worsen RV function in other animal models of pulmonary hypertension. So even in normal individuals without pulmonary hypertension, there appears to be some differences in baseline RV morphology and function. These are two papers published by Corey Ventitulo. I mentioned her before, and she dove deeper into this phenomenon, looking at sex hormone levels and the RV in MESA, and I've basically listed the findings here. First, higher estrogen levels were linked with better RV ejection fraction, specifically in women, and specifically in women receiving hormone replacement therapy. Remember that this first exam for MESA was done in the year 2000 to 2002, before we knew the dangers of estrogen supplementation, and so about a third of women were actually taking hormone replacement therapy at that time. She also found that higher circulating testosterone levels were linked with greater RV mass, specifically in men, and that differences in CYP1B1 genotype were actually linked with RV ejection fraction in women, whereas androgen receptor genetic polymorphisms were actually linked with RV mass in men and actually moderated the effect of testosterone. So I think the takeaway from this slide, and there's a lot here, is that there's sex-specific, genetically determined differences in both estrogen metabolism and androgen signaling, which may impact on the RV in a sex-specific way. So what's good for women is not necessarily good for men, and vice versa. And so I think that just increases the complexity even further. Why did we only see association between RV ejection fraction and estrogen in women on HRT? Well, women on hormone replacement have greater estrogen levels than usual, and there may be more variation, and this may have brought out these differences. There's a variety of unmeasured metabolites, and so maybe these are the metabolites which are actually causing the RV findings. Hormone replacement therapy does very funny things to protein receptors and interactions, and HRT is actually known to upregulate estrogen receptor expression. And of course, there may be unmeasured differences between those women using HRT and those not using HRT, which may explain things. But it's possible that higher levels of estrogen in these women promotes angiogenesis, and maybe that's why they have better RV ejection fraction. But I think the jury is still out. So in summary from the MESA data, it looks like women, adult women, without clinical cardiovascular disease have higher ejection fraction than men, and that estrogen and testosterone levels and genetic variants in these pathways affect men and women in different ways. But this is all well and good for normal individuals. What about our patients with PAH? So this is a study published by Corey using the FDA data that Rohan mentioned. So we have data from the FDA from all clinical trials of pulmonary hypertension medicines. And so she looked at 1,200 untreated patients with idiopathic PAH who were enrolled in a registration trial for PH therapy, and the trials are listed on this slide. 303 men, 908 women with hemodynamics, similar ages, similar race, similar body mass index, and similar in terms of functional class. Here's where the differences start. When we looked at men compared to women, untreated, men had about a 1 millimeter higher right atrial pressure. In addition, when we looked at mean pulmonary artery pressure, individuals who were younger, so younger men and women, men had about a 5 millimeter higher PA pressure compared to women, but actually we saw no differences in the older ages, after menopause notably. Men appeared to have lower cardiac output compared to women, and men appeared to have higher PVR compared to women. And this was adjusted for age, race, body size, and study. So it appears that at baseline in PAH, in a large cohort of patients, men appear to have worse hemodynamics compared to women. Well, I mentioned the RV before. We all know that the RV is probably the most important determinant of outcome in pulmonary arterial hypertension. And this slide really drives that home, and in some ways is very concerning. These are data from about 65 patients, incident patients from Columbia when I was there, who all had SPECT scan or nuclear scan with first pass, and so had RV ejection fractions before receiving treatment. And the lesson I take from this slide is the RV ejection fraction you walk in with at baseline determines the rest of your life in pulmonary arterial hypertension. No matter how you're treated, no matter what you do, no matter what your PVR is, if you walk in the door with an RV ejection fraction of greater than 34%, then 10 years out, you are most likely going to be alive. On the other hand, if you walk in the door with an RV ejection fraction of less than 23%, you're in big trouble. And remember, this is in the era of endothelin receptor antagonists, PDE5 inhibitors, parenteral prostanoids. So the RV function you walk in with is the RV function which determines your outcome. Well, is there a difference between men and women in RV function at baseline? So when we looked, indeed, women who walked in the door had a significantly higher RV ejection fraction compared to men. This is about a 6% difference in RV ejection fraction. And again, this was independent of pulmonary vascular resistance. So independent of the severity of their pulmonary vascular disease, women have much better RV function compared to men. And we went on to look at this in a cohort from Amsterdam. This is with Anton von Noordegraaff, where he showed in idiopathic pulmonary arterial hypertension that, once again, men have a worse survival compared to women. Now, what's nice about their cohort is they have serial assessment of RV ejection fraction using MRI. And we found that women treated with pulmonary hypertension had about a 5% on average increase in RV ejection fraction. On the other hand, men treated with pulmonary hypertension had not only not an improvement, but a somewhat of a decrement in RV ejection fraction over time. And we showed that about 40% of the differences in outcomes between men and women were accounted for by changes in RV ejection fraction. So I think this is really clear that the reason why women are living longer than men, at least in some part, is because the RV responds better in women than men to treatment. And again, this is after adjustment for a variety of confounders and baseline RV ejection fraction. We have another study where we looked at response to pulmonary hypertension therapy, again using the FDA data. We looked at 1,100 untreated patients with PAH enrolled in a randomized clinical trial of an endothelin receptor antagonist compared to placebo. These are the list of the studies. There were 773 patients randomized to an ERA and 357 patients randomized to placebo. When we looked at the change in 6-minute walk distance from baseline to 12 weeks by sex, we saw that there was a different efficacy of this drug, of these drugs in women compared to men. So in women who received active treatment, they had a 36-meter increase in their 6-minute walk distance. Women treated with placebo, around 10-meter decrease, giving a placebo-corrected treatment effect of around 45 meters. On the other hand, when we looked at men randomized to active treatment, only a 20-meter increase, with a small actual increase in those treated with placebo, so with a much smaller placebo-corrected treatment difference, so with an interaction of around 30 meters. So it seems that women have a greater placebo-corrected treatment effect of endothelin receptor antagonists compared to men. And again, this was adjusted for a variety of confounders. So to go back to my slide before, why do women with PAH survive longer than men? Well, I think all of these statements are true. Women appear to have better baseline right ventricular function. They appear to have less severe pulmonary vascular disease. They appear to have better improvement in RV ejection fraction with treatment. And in terms of drug therapy, women may have a better response to 6-minute walk distance with ERAs. So what's the future? I think we're just beginning here. I think really it's only been around 5 or 10 years when folks have been actively investigating the role of sex and outcomes in pulmonary hypertension. I think we need more mechanistic studies, clinical trials of sex hormone-targeted therapies, planning for sex-specific analyses, both in clinical trials as well as in observational or epidemiologic cohorts. And a precision medicine approach, you know, it's great to check proteomics or to do a GWAS, but it's much easier for me to ask if you're a man or a woman in determining how to treat you. And it's not sexy, and it doesn't cost a lot of money, and the word exome doesn't appear in it. But if we can determine treatment based on sex, you know, potentially we can do better by our patients. As you can imagine, all of this work over the past 12 to 15 years has really taken the efforts of large numbers of people. The slide is probably incomplete. It includes all of my team at Penn, research coordinators, as well as my faculty members, Johns Hopkins University, where the reading center for MESA was, the place where these two folks, Harjeet and Adi, read 4,000 cardiac MRIs for RV function, the most mind-numbing job you could ever have, and they'll attest to that. Anton for his collaboration, Corey for being such an amazing mentee and now colleague and friend, Robin J. Barst, one of my first clinical and research mentors, who unfortunately passed away, who oversaw me at Columbia, and then a variety of other individuals as well. So thanks for your attention, and I'm happy to take questions. Mark. Did I know the answer before? Yeah. Brave is not a term I'd apply to myself. Foolish, maybe, but not brave. Yeah, no, it's a great question. It's one of the reasons we chose TAPSE as our primary endpoint for the pilot study, because if there was worsening RV function, we wanted to detect it. Also remember that anastrozole has been used by hundreds of thousands of women with zero safety signal in terms of heart failure. And so you would think, many of those women have pulmonary hypertension, they have HFpEF, sleep apnea, and you would think if it did something bad to the RV, it might have come out in its use in the general public. But it's a distinct possibility, and I think this is why we need to do the study. Hey, David. How are you? Very well may be possible. I mean, for all these analyses, we adjust for PVR, but of course, that's a blunt instrument. And so maybe there's compliance or other factors where we have unmeasured confounding, and that this is still all pulmonary vascular function. That's very possible. PVR is a pretty good measure of the vasculature and severity of pulmonary hypertension, so you would think we would eliminate it there, but I can't prove that. And I think the best way to prove the point is if we come up with an RV therapeutic that purely targets the RV and we improve outcomes, I think that's the only way to know that, is it truly the RV or is it just worse pulmonary vascular disease? Hey, Francois. Yeah, no, and it's a good point, and I'm trying to remember if stroke volume was different in the body size adjusted analysis in MESA, but there are certain things that you'll be able to detect by EF, where stroke volume may remain normal, right? The heart may dilate just a little bit, and while EF may be going down, the stroke volume will remain the same. So the question about which is the right parameter to look at, I think, is unclear. I mean, RVEF to me seems like the right parameter to look at in pulmonary hypertension, but again, this is a resting parameter. Maybe it's stroke volume increase with exercise and augmentation. So I don't think the jury's out for what exactly the right measure is. Someone in the back. It's a good suggestion, and it's quite possible. We know that men are less perceptive than women. Speaking as a man, I can say that. My wife would agree. And it may be possible that we're seeing patients at different times in their disease. Some of the stuff that goes against it is the response to therapy. So even after adjusting for baseline differences, after adjusting for baseline hemodynamics, for example, in the Dutch cohort, we saw differences in change in RV function in response to treatment. Sure, that could be that the RV is at a later stage and can't respond, but you would think by adjusting for the hemodynamics they walk in with, that somehow we're accounting for their stage of disease. But it is a possible explanation.